Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I am Chris the Chew Man Chew. I am joined by a bunch of awesome people that I like today. I'm with Sam Mazer. Hey, Sam, how are you doing?
Hey, everybody.
And I am also with Alice Shanklin? Alice
Shanklin, like Franklin. Happy to be here.
And Zach Hodges.
Hi, glad to be here.
And we have a great guest tonight is Dr. Chris Horvat, who's going to discuss sepsis and sort of some of the new guidelines or new criteria for sepsis that have just been published. But first, before we get to that, Sam, do you want to remind us a little bit about the show?
So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
Now, Zach, we're really happy for you guys to partner with us. Do you want to tell us a little bit about your podcast that you and Alice are on?
Yes, and thanks so much for having us. So, Pediatric is a collaborative educational PICU podcast working with pediatric critical care educators around the world to create high-yield podcast episodes on core PICU topics.
Yes, if this 2 hours on sepsis isn't enough for you, come on over to Peds Crit. We have hundreds more hours. But today we're talking with Dr. Chris Horvat about the Phoenix sepsis criteria. Dr. Chris Horvat is a pediatric intensivist and informaticist at UPMC Children's Hospital of Pittsburgh. He is a big data guy. He also co-authored the new pediatric Phoenix sepsis criteria published in early 2024. In this episode, he's teaching us about these new criteria, the surviving sepsis guidelines, and how the two are intertwined.
All right, listeners, you better bundle up because we're going to get a big bolus of information.
Well done.
Yeah, that's good.
Dr. Chris Horvat, thank you for coming on the show.
Yeah, I'm thrilled to be here.
Because we are an informal group, would it be okay if I addressed you by your first name?
Yeah, that's totally fine.
And for everyone else, just call me the Chew Man, just so we don't have so many Chris's on the show.
All right, this is going to go well, everybody. We're going to be quite confused, but we'll get to all the Chris's, yeah.
All right, so I'm just going to start. So do you mind, Chris, since this is the first time you're on our show, could you describe yourself a little to our listeners about who you are, maybe a little something outside of medicine that characterizes you?
Sure, yeah, happy to. I guess I would say that I'm a father of two, husband of one, learning health systems researcher. I'm a Canadian who grew up in the Appalachian Mountains and now practice pediatrics, intensive care, and clinical informatics. And I think it's probably in part from the geographically disparate areas that I grew up that I have this ongoing internal struggle between the systems approach to medicine and the need for rugged physician individualism as we take care of our patients.
Very cool.
Yeah, who's going to hit the follow-up question to that? Because that is a tough thing to unpack. Seriously. Tell us more. What do you think about this individualism piece?
Yeah, I think because we're talking about sepsis today, I think it's something that certainly comes to mind when we think about consensus definitions and defining things at a population level, and then how that actually translates to individual physician decision-making, diagnosis, and treatment plans that are catered to individual patients. And so I mention it in part because I think it's appropriate for the theme that you've invited me to discuss today.
Oh, this is excellent. This is like a perfect teaser. I mean, we're going to literally talk about this, and I actually am just getting excited just to think about how you're going to break down some of these definition pieces. With that as just kind of a teaser piece, I'm actually going to move on to the next question because maybe this could be related too. What is your favorite failure, and what did you think you've learned from it?
Yeah, that's kind of a loaded question, and there's definitely there's a lot to choose from there, and I'll have to be careful about the ones I choose, I suppose. I guess one that comes to mind, so in my spare time, I'm a big do-it-yourselfer. When I became an attending, I took up carpentry as a hobby. And one of the things I decided to do was to install judges paneling in my basement for a couple of reasons. One, I thought it would look nice. Two, it was going to be in my basement. So if I messed it up, it seemed to the ramifications would be less in that case. So I bought a bunch of tools. I watched some training videos, read some books on how to make judges paneling, spent countless sort of off hours on it. Like late at night, I'd be down in the basement sawing wood and gluing and nailing things in with my brad nailer. Eventually, I finished it, and it looked terrible. And the stain was awful. There were a couple of panels that were bubbled, and I was not happy at all with how it turned out. And so I stepped back, took a breather, ended up sawing out some of the panels that I had put in, painted over the stain, went for a two-tone look, replaced some of the panels and covered up the seams with some trim. And I don't think you can tell at all that I had screwed it up so badly the first time around. It just took some recalibration of the approach to make it look better. And so, certainly there were lessons in that, and that the process may have been nonlinear, but we arrived at a pretty good endpoint. And I think I reflected on it at the time, thinking, well, that's pretty emblematic of how I end up getting to a lot of places, kind of circuitously, but the end product often looks okay.
It's almost like a carpenter's PDSA cycle right there. You did. So what went
right.
wrong? How can I fix it? And everything.
That looks terrible. I thought, yeah, that was the analysis there. So,
any other questions we want to ask, or should we start jumping into our case?
No.
Have you ever had one of those crazy clinics? You start off with 10 patients, and suddenly there are 13. Everyone is sick. The EKG stickers won't hold. Well, at the end of the day, the task of charting can be daunting. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Instead of trying to remember everything that happened, your notes are already there, ready for you to copy and paste into your EHR. Freed saves you time and works across all devices. You can use a phone, tablet, or computer to listen in the room and switch seamlessly to your desktop to review and finalize. Behind Freed are two people who understand. Gabby, a family doc who is drowning in documentation, and her husband Erez. They built Freed with a simple promise to make clinicians happier. Not by pushing them to see more patients or optimize their billing, but by giving them back their time. We're happy to report that thanks to Freed, Gabby has traded Saturday morning charts for Saturday morning croissants. So at your next clinic visit, when you put your hand on the doorknob and your patient says, "One last question," instead of scrambling to type and listen, take a deep breath as Freed writes it all down for you. Join more than 15,000 clinicians, doctors, NPs, and PAs who trust Freed's encrypted, HIPAA-compliant, high-tech, and SOC2 certified platform. Start your free trial today. No credit card needed. Visit freed.ai. Use code CURB50 to get $50 off your first month.
Dr. Chris Horvat, we are so excited to talk about sepsis today, and I am going to get us started with a case. So you're seeing Sep, an 8-year-old previously healthy boy who's coming to the emergency room for respiratory distress. He was seen by his pediatrician 3 days ago for cough and fever, diagnosed with pneumonia, started on high-dose amoxicillin. Unfortunately, over the last 3 days, his fever curve has been getting worse. He's sleeping more, drinking less. This morning, parents barely wake him up. They check his temperature, which is 103 degrees Fahrenheit, and found him belly breathing, one of the signs they were told to look out for by their primary pediatric team. They rush him into the ED, where in triage, he has a temp of 39, a heart rate of 140, a respiratory rate of 30, an oxygen saturation of 86%, and a blood pressure of 85/50. So we're really here today to talk about the new sepsis definition. But before we get into all of that, which patients are we suspicious for? Which patients might have sepsis?
I think what I teach to trainees and what I would offer to really anybody who's potentially encountering children in their care, any clinician, is that you should start thinking about sepsis the moment someone has a possible infection and they need any sort of medical assistance at all. That's when the sepsis light bulb should go off. So for all the complexities of the past and present definitions, it really does boil down to a pretty simple decision-making process, which is, could there be an infection, and does this patient need medical help?
As we're sort of looking at this case, my inner stomach does this thing where it does like sick versus not sick. And I feel this is one of those lessons that you get as you progress through your training. And when I look at this kid, he's probably febrile. With him being febrile and doing belly breathing, I'm looking at him as like a general pediatrician. I'm thinking sick. When you think sick versus not sick, is that always equal sepsis or not?
That's a good question. Probably a tough one to answer with a general statement, because kids can look so good until they don't, I think, as we all know as folks who have trained in pediatrics. And it can be striking how deceptive they are. And I feel like I've started to learn that in a decade of practicing pediatric intensive care, and even still taken aback sometimes by kids who could be sitting there talking to me. They can look okay. They can even have good peripheral pulses, and you take a cuff blood pressure and it's profoundly hypotensive, for example, and you repeat it and it turns out it's real once you put the arterial line in. Or the horror stories, I think, that happen incredibly infrequently, but the kids who are looking fine, they kind of fool everybody, and then a catastrophic event occurs. That's something that, especially the folks who have been around a children's hospital for a while, will tell you that they've seen more often in the past, thank goodness, compared to the present. But it's tough, and I think that's the first thing that certainly comes to mind as Alice is reading this case here, which is the decision you face immediately is sick or not sick, and that's a really, really difficult decision in many cases.
So I think actually we should just take this moment right now to start defining sepsis a little bit, and then we can kind of circle back around and who we should really be concerned for. It sounds like right now off the bat, Chris, you're saying anyone you're thinking infection, you should at least be thinking sepsis in the back. So let's just work with that to begin with, and let's start with trying to define sepsis, and then let's kind of walk our way back. So you were part of the Phoenix group that came up with this new definition for sepsis. But before we even get there, can you kind of take us through the old definition and why it might need a change?
Yeah, so the old definition was the 2005 International Pediatric Sepsis Consensus Criteria, the IPSCC definition, which was really centered around a combination of a suspected infection and SIRS criteria. And SIRS criteria are combinations of basically vital sign aberrancies, and you had to have two or more of those, a combination of low heart rate or high heart rate, fast breathing, respiratory distress. And so these factors that suggested that the body was systemically inflamed. That definition had obviously been in place for a long time, and in some ways worked really well. And I think that's part of the discussion that we're going to be seeing as the Phoenix criteria disseminate and folks start interrogating them separately from the initial publications that came out a few months ago. But they were commonly criticized for lacking positive predictive value at the bedside, meaning that children could have a number of other reasons for having a high heart rate or breathing fast that weren't related to disseminated infection, weren't necessarily life-threatening, and shouldn't necessarily be labeled as sepsis, and might take clinicians down, if they did label them as sepsis, might take them down a treatment pathway that wasn't really beneficial for patients. And so there'd been a lot of discussion over time about updating those definitions to improve the precision or the positive predictive value of them to aid clinicians who are trying to make these diagnoses.
I think that's really helpful. When I think about sepsis, I do think of that positive SIRS criteria plus suspected infection, but also when I reflect on walking around the pediatric ICU, gosh, I feel like more often than not, they're going to be SIRS positive and maybe have infection. And all of a sudden I'm thinking, does every patient have sepsis? Well, of course that needs to be on your mind, but it's probably not true. And and when this new Phoenix sepsis criteria came out earlier this year, it was a big splash in pediatric critical care. We're all looking for, how do we find that needle in the haystack? Which kid is actually septic? Maybe at this point, when we get into exactly what is the Phoenix sepsis criteria, what are the components, and how do we make that diagnosis?
Yeah, so the new Phoenix criteria are a point-based system that span 4 organ systems: respiratory, cardiovascular, coagulation or clotting, and the neurologic system. And in order to be considered to have sepsis, you have to accrue 2 points across those different systems. In order to be considered to have septic shock, you have to have 2 points with at least one of those points coming from the cardiovascular box, so cardiovascular dysfunction. And this is a definition that was arrived at in a data-driven fashion, collecting data from multiple sources from around the world and applying a data science technique known as meta-regression to evaluate what the best point-based systems were across these organ systems for identifying patients at highest risk for mortality as the main outcome.
And if I understand it correctly, like this was as evidence-based as you possibly can be. And by that, I mean, it was like much more evidence-based than the previous model, being that we started out with an international survey, figuring out what clinicians actually wanted, how they want to define sepsis, followed by systematic review, looking at all of these individual variables, and then a data-driven approach to validate which variables actually predict mortality. Is that correct?
Well, yes, you're exactly right that it was very rigorous and extraordinarily systematic in its approach. They conducted, as you said, a survey across clinicians and identified that most clinicians consider sepsis to be an infection in the presence of organ dysfunction. The team looked at the organ dysfunction scores that had already been created, things like the Pediatric Logistic Organ Dysfunction Score 2 and the PSOFA, the Pediatric Sequential Organ Failure Assessment, and developed a model that really drew from these different approaches that had already been validated previously to determine what combination of the different organ systems and the scoring approaches were most associated with mortality across several million children from a variety of different data sources. I guess I want to back up, though. One thing that you mentioned there, Zach, was the evidence-based approach. And one thing that that brings to mind is actually what we define as an evidence-based approach. And so I would say that this was highly rigorous and highly systematic and absolutely qualifies as evidence-based. But I always like to remind folks the origin of actually the term evidence-based medicine. And not everyone is aware actually that it was coined by David Eddy, and I think it was 1991 in one of his JAMA commentaries. And the way that it originally developed actually was he was discussing the application of Bayes' theorem at the bedside. So what's your pre-test probability? What information can you collect from the individual patient? And how does that influence your post-test or your post-assessment probability and your decision-making at the bedside? And the reason I bring it up is because it leads me in my mind at least to circle back to some of the original things you're already mentioning from a standpoint of themes that come to mind when we think about sepsis definitions, which is evidence-based can mean a lot of things. And there is an evidence base that's formed from treating individual patients, and then there's also an evidence base formed from these highly systematic, rigorous approaches to crafting definitions that apply at the population level. And so absolutely, the Phoenix criteria were the latter, but it doesn't necessarily obviate some of those individual decisions that I think we still are going to face at the bedside as we're trying to decide how do we manage these patients with potentially life-threatening infections.
Am I right to say that you started in a situation where the old definition of sepsis is maybe kind of more focused towards screening everybody meets criteria, decided to redefine it as the children with life-threatening organ dysfunction from an infection who might die, and then had a giant database of all these children and looked at the ones who actually died and then used that to sort of let the variables come to the top?
Yeah, that's right, and did so across both well-resourced and settings with limited resources as well, with the intent of creating a definition that would be globally applicable across different healthcare environments. And then, ECMO is used much more widely than it was even a couple decades ago, and so sought to create a score that had good statistical performance characteristics, not only for mortality, but also looking at things like death or ECMO, which is a salvage therapy that we're fortunate to have these days. And so those were other aspects that really work to modernize the definition and account for a variety of settings that hadn't at least been mentioned as much in the forefront in previous definitions.
Hey, Cribsiders listeners. Although it may only be halfway through the academic year, it's officially 2025, which means it's New Year's resolution time. We all set such healthy goals, but why are they so hard to keep by year's end? It's mostly about time. For those in medicine, time is our most valuable resource, and it's hard to find more of it. But imagine if you could automate those goals. If your goal this year is to grow your money, Acorns has your back. With Acorns, you can lock in years and years of healthy money habits in just 5 minutes. That's all the time it takes to open your account and start automatically saving and investing your money so it has a chance to grow. Acorns makes it easy to start automatically saving and investing so your money has a chance to grow for you, your kids, and your retirement. You don't need to be an expert. Acorns will recommend a diversified portfolio that fits you and your money goals. You don't need to be rich. Acorns lets you invest with the spare money you've got right now. You can start with $5 or even just your spare change. I've always been taught the earlier you invest, the longer compound interest has to work. When it comes to investing, the best day to start was yesterday. So start now with Acorns. Head to acorns.com/Cribsiders or download the Acorns app to start saving and investing for your future today. This is a paid non-client endorsement. Compensation provides incentive to positively promote Acorns. Tier 1 compensation provided. Investing involves risk. Acorns Advisors LLC, an SEC registered investment advisor. View important disclosures at acorns.com/Cribsiders. So just moving a little bit back to the definitions for our audience members, we kind of talked about 4 systems. We mentioned respiratory, cardiovascular, coagulopathic, and a neurologic component. Can we kind of talk about each of those individual components so then we can kind of get into like, all right, how do I get a score of 2 and what is that really going to mean for us as we move forward?
Yeah, absolutely. I'm happy to go through them.
Yeah, that'd be awesome.
So taking the respiratory category first, that was really based on P to F ratios or S to F ratios, so PaO2 to FiO2 or SpO2 to FiO2 ratios. And if you're above 400 on the P to F ratio, you get 0 points. You get a point if you're less than 400 and you have some sort of respiratory support. And you get 2 points if you have a P to F ratio that's 100 to 200 with invasive mechanical ventilation. And then 3 points if your P to F ratio is less than 100, which means you have very severe lung disease and you're receiving invasive mechanical ventilation. The cardiovascular point system be 0 points for no vasoactives or lactate elevation. So, and actually a lactate elevation is considered greater than 5. So if your lactate is less than 5, you get 0 points.
It's a high bar.
It is. It's an arguably higher bar, and is one of the components, perhaps, of the score. And as we go through the rest, there may be others worth highlighting as well that I think are also reflective of looking at a mortality outcome in a more modern data set based on some of the incredible accomplishments that have been achieved in the space of sepsis over the last couple of decades. And so additional points for the cardiovascular system. You get 1 point for a vasoactive medicine where your lactate's 5 to 10.9, and then 2 points per either greater than or equal to 2 vasoactive medicines, lactate greater than 11, or hypotension. So 2 points for each of those, and you can get up to 6 points in the last category. And then in the from the coagulation standpoint, you get 0 points if your platelets are above 100 and your INR is less than 1.3, your D-dimer is less than 2, fibrinogen's greater than 100. 1 point if your platelets are less than 100, INR is greater than 1.3, D-dimer is greater than 2, fibrinogen's less than 100. And then finally the neurologic box, which is 0 points if your GCS is greater than 10. 1 point if your GCS is less than or equal to 10, and 2 points if your pupils are fixed bilaterally.
So I have some follow-up questions just from kind of a practical manner. The cardiovascular box, although we talked about being a high bar, kind of makes sense. The coagulation bar also makes sense. You look at your labs. From a respiratory standpoint, a lot of the patients you might see in the ICU are intubated, but the ones who aren't, so are we getting gases, for example? Well, actually, we'll get into the question for it, but if you get a gas for someone in room air, that's fine. What are we doing for the patients who are on just like nasal cannula? What are we using for our F, really, is where I'm getting at for most of these patients?
Yeah, I think in those situations, you're talking about an estimate at the bedside, and there's I think increasing adoption in recent years to incorporate the S to F ratio into practice, in part because we're using arterial lines and drawing less PaO2s than we've ever done before. We always joke in Pittsburgh that we probably place a lot more arterial lines than a lot of other centers, and even our relatively assertive management strategy has shown that we're placing less arterial lines than we have in the past. And there's a nice body of literature to support the decision making surrounding using S to F ratios to manage lung disease. They've been shown to correlate well with P to F ratios. They are associated with disease severity. They've proven useful in organ dysfunction models before this, and so this wasn't the first time that an S to F score has been incorporated into this type of tool, but it does reflect a practice change over recent years. And this is something that wouldn't have been mentioned as much in the forefront, right? Just a few decades ago.
Same with these respiratory points. Sometimes thinking about patients can make it a bit more clear, and these are broad strokes. And the SF and P to F ratios are much more precise. But if you were to think about a 1 point for respiratory, might be that kid on supplemental oxygen. Venturi mask, high flow nasal cannula in the PICU. 2 points intubated. On 40 to 50% oxygen, so some lung disease, but not too severe. And then at 3 points, 60, 70% oxygen. High severity lung disease.
So those are sort of good rules of thumb when we think about them just sort of by the bedside.
Nice. No, that's great. And then just flipping over lastly to the neurologic box to kind of clarify, I feel like a lot of these patients also, as you said, kind of will end up getting intubated as we just went through the whole R situation. How are we doing neurologic discussions when our kids are sedated?
Yeah, good question. So sedation holidays have been an increasingly popular, I guess you would say, or increasingly adopted strategy to make sure that you're getting a good neurologic exam on a regular basis for patients who are receiving continuous sedatives. So that's really become the standard of care, in part through SCCM like A to F bundles and ICU liberation bundles, doing spontaneous awakening trials every day. But it can be challenging, and sedation is absolutely a confounder for many of the children that we're taking care of who are requiring mechanical ventilation.
I just realized, actually, and Zach, this might be a point that you were going to say, I guess if you're intubated already, you've already reached a score of 2. So in this case, you're kind of like, we're good here from a practical standpoint. And of course, you're going to have to talk about the research component of it and what that's going to mean in the future. But I guess from a practical standpoint, you're already thinking sepsis if they're intubated.
Yeah, no, that's a good point, but it does factor in terms of how the score is interrogated moving forward as well. As we look at external data sets and we look along the complete continuum of the score, and we try to understand exactly, what are the drivers of mortality, what are the things that we want to focus on, how is the tool going to be useful for clinical trial enrollment, which is one of the things proposed in the publication. It's an important question. I do a lot of research with electronic health record data. Teasing GCS apart from the sedatives that have been administered recently is very difficult to do with programming, if not entirely impossible. And so there's absolutely that confounder in this tool, and it's something for clinicians to be aware of as well.
So from a clinical standpoint, so I think you said a score of 2 or greater sort of helps us define sepsis. What do these numbers mean for me by the bedside? Like, is a higher number mean there's a higher risk for mortality? And then can you sort of give me a rule of thumb exactly what those numbers actually mean, and how often should I be recalculating to make sure I'm going in the right direction, or like what's the sensitivity of the score overall?
Yeah, those are good questions. So I guess the first thing I would say is that, I think that these are important entry criteria for identifying patients who qualify for this consensus definition. I can imagine scenarios where you'd think about recalculating them to feel better about circumstances as a patient potentially improves. In terms of what they mean on a daily basis and how the temporal trends of this score are going to eventually prove or not prove to be associated with specific outcomes, that's an area of opportunity and an area of further inquiry that I think the door is open to now that these initial definitions are out. And so I think wanting to get calculated on a regular basis after a patient's already qualified for sepsis is a natural thing to do as a clinician. What to do that with that information? I don't know that I can tell you, actually, because I think that once your patient has actually met the definition for sepsis, you, I think, have achieved a level of stratification that your management is really going to be guided on an individual basis anyways from that point moving forward. We do know, you asked about the sensitivity, and the sensitivity of the score is improved from the previous definitions. And so depending on the outcome that we looked at in the resource settings, the level of resources across the different settings that we looked at, the sensitivity was in like the 60 to 80% range and tended to be better than the IPSCC criteria definition. But where the score really proved to be superior was when we looked at something called the AUPRC, which is the area under the precision recall curve. And the AUPRC seemed to be markedly better in some cases compared to the old definition by way of its increase in precision or positive predictive value. And so there were benefits in terms of sensitivity, and then there were also benefits, sometimes more so, in terms of positive predictive value of the score.
And then I don't know if we actually said this out loud, and if we did, I apologize. We can just say it again. With each of these components is a certain respiratory, cardiovascular, coagulopathic, neurologic. This is all assuming that we have a somewhat suspicion for infection. Is that correct? Or is this for anything universal, regardless of what our suspicion for infection is, like the SIRS criteria?
No, that's exactly right. There's a suspicion for infection here. And the entry criteria into the cohort that were used to derive this score required a culture and an antibiotic. So a culture was obtained and an antibiotic was administered. So the cohort of children that were used to derive this score were suspected of having an infection.
Okay, awesome. I just wanted to make sure we said that out loud, clarified that, be as clear as possible. Even if we said it already, repeating it is always good for active learning.
Absolutely.
And is our age ranges, is it from birth? So this can apply to all our newborns all the way up to my 17-year-old. And like, what is my age range and what was the cohort you used to do your studies and validation?
Yeah, so this applies to all children, but of course the neonatal sepsis is something that I think is going to warrant additional interrogation and examination of the score. And for good reason, we all know the neonatologists tend to do things a little bit differently in their world, and their patients are a little bit different when it comes to risk factors like the immune system development and the types of infections that those children tend to battle. And so while this is broadly applicable to pediatric patients, I think that there is going to be more evidence that needs to be generated, and this is my perspective, but more evidence that needs to be generated for the neonatal population in particular.
Chris, I got a more like an expert approach kind of question for you here. Really, just how you think about these patients. When you're taking care of a patient who has sepsis, maybe septic shock, do you think of them as this is a kid with a Phoenix score of 6 that in your mind kind of registers where they're at in their severity, or do you think of them maybe like I think of them as a early career attending? This is a kid with organ dysfunction, and I think they have infection. Whether that be pediatric ARD associated with sepsis. And I think of them as an organ system specific. I don't necessarily intuitively think of them as their Phoenix score of 6 to 8 or whatever it is. How much of this data actually is in your mind when you're treating these patients?
Yeah, that's a good question. What it brings to mind, Zach, I think you mentioned a moment ago, when you look around the ICU, a lot of kids can potentially qualify for sepsis, especially using the old SIRS-based definition. And I'd say when I look around the ICU on any given day when I'm on service, I would say that a large majority of the children do have sepsis in my mind. And some of them meet the Phoenix criteria. Those that I'm still, I'd say, worried about sepsis based on this new definition or highly suspicious of sepsis may still have a life-threatening process going on, even if they haven't accrued the organ dysfunction to meet the scoring criteria that are outlined by the Phoenix criteria. And this is actually something that's really important that I like to highlight when I talk about the Phoenix criteria with folks and with trainees, which is that The Phoenix criteria haven't really changed my approach to identification and management of sepsis. That's really stayed the same, in part because I had the privilege of training with giants in the space of sepsis, people like Joe Carcillo, who, when he was a fellow, put out the JAMA paper that fluid resuscitation is beneficial for children who are presenting with concerns for sepsis, but also because I think actually identification and management of sepsis really boils down to three core things, and I don't think of them in terms of a score. So I think about what is the either potential or identified infection at play. What is the individual patient's host response or biomolecular response to that infection? And what are the systems of care surrounding that situation for that specific patient? And the reason that's so important is because, the 14-year-old adolescent who shows up with urosepsis, and you're called as an intensivist to the ED because their heart rate's 180 and their blood pressure's okay, they're not going to meet Phoenix criteria, and they probably won't if you do things well, but they might if things don't go the way that they should. And so I think that the Phoenix criteria are an incredibly important milestone in the space of pediatric sepsis, and I think that there's likely to be ways that they're going to prove to be highly useful, but they haven't changed my practice yet in terms of how I'm approaching, recognizing, and treating patients with potentially life-threatening infections.
I mean, this is a perfect transition to where we were going to go next. You've already teased a little bit about how we should identify and or treat sepsis. We recognize that this is the Phoenix definition, but not the actual treatment guidelines. So we might just change our role ever so slightly right now to talk a little bit about treatment, treatment recognition, testing, all that kind of good stuff, which we'll get into in a second, and then we'll kind of link back with kind of the Phoenix criteria at the end. So now that we've defined this, let's kind of move to the the Surviving Sepsis Campaign's clinical practice guidelines for our patient. That, if you guys all remember, this was our 8-year-old with the cough and the fever, now coming in tachycardic, tachypnic, hypoxemic, and hypotensive. So going back to the ED, when we suspect infection for a patient, what workup should we be getting on every single patient with one of these suspicions for sepsis?
Yeah, I love that question. And it actually leads me, so I want to call out a couple of things about this fantastic case, right? Because this is such a common scenario for those of us who practice pediatrics in the inpatient setting. And some of the things to highlight here is, appropriately, this patient's got pneumonia and has been started on high-dose amoxicillin. The IDSA guidelines were published in 2011 for community-acquired pneumonia. We're 13 years later, and we don't have an updated set of guidelines. It's not that prescribing amoxicillin is the wrong thing to do, but the best evidence we have should probably be labeled defunct at this point. And actually, if you look at the AAP standards for updating guidelines, they're supposed to be updating guidelines every 5 years. And so this is a conversation I've had with folks who led the previous bronchiolitis guidelines, which is like, we actually don't really have bronchiolitis guidelines right now because it's been more than 5 years, and the AAP standard is updating them at least every 5 years. So it's fantastic in that regard. And actually, I use this exact point for trainees as well, because I often use this as the segue into pimping trainees and say, well, tell me the most common 3 causes of community-acquired pneumonia. And, the sharp ones, many of them are, I would say actually all of them here in Pittsburgh will often get it. They'll say, strep pneumo, Haemophilus influenza, Moraxella. And I'll say, well, tell me about the amoxicillin susceptibilities of those infections. And we use high dose because there's a subset of the strains of strep pneumo that require the high dose in order to overcome the penicillin binding protein mutations. And then there's a greater proportion of Haemophilus that's intrinsically resistant to amoxicillin because it's a beta-lactamase. And then the majority of Moraxella strains are resistant to amoxicillin, right? It's like 95% of Moraxella is resistant to high-dose amoxicillin. And so maybe the next version of the community-acquired pneumonia guidelines are going to tell us to keep using amoxicillin instead of ceftonir, which would get all 3 of those bugs, or augmentin, for example, which would be another really potent choice. But the jury's kind of out. And so I'm apologize, a little bit long-winded here in terms of your question, which is how do I approach treatment here? But I approach it conservatively. And I really, I think about it, especially if I'm being called as the intensivist into a scenario like this. I'm thinking about what are the things that I need to do now knowing that bundle compliant care is so important for reducing mortality and improving outcomes, to initiate a diagnosis plan and start treatment. And that ends up being very individualized. I would say that there's no single set of labs. There's no specific antibiotics that I necessarily order, but I look at the patient-specific risk factors. I will say that I do my best to get cultures before I start antibiotics, though, because many of our patients are going to need a de-escalation strategy a day or two down the road, and you really want to do that with data. And the ID docs, for good reasons, don't love when we call them and say, well, we didn't get cultures, and we need to know what to do now with the Zosyn. So it's an individualized approach, and it's individualized because the pathogens are different and because the patient's biomolecular responses to those pathogens are different on a case-to-case basis.
So maybe we'll start just with this case here, just for someone who we think is coming in with some sort of respiratory complaint as the primary piece to the puzzle. Kind of where would you start from a workup? We'll get into medicines in a second, but where would you start in a workup for this patient kind of who hit the emergency room was coming through?
Yeah, I mean, this is it's a great example of your initial triage really involves the ABCs. You have a hypoxemic patient here who is also showing some hypotension as well, and there's an immediate need for some initial resuscitation in this situation. And you also have the benefit of a history that says that they've been on some antibiotics for a while, and it doesn't seem to be doing the job that you hoped it would in this situation. So, at our institution, we would approach this patient. Our ED is excellent. They'd have this patient on oxygen, I'm sure, before you could even blink. They'd probably have IVs in very quickly. They'd be administering a fluid bolus almost immediately. I'd say that there's an order of things that we would do, but they probably all happen pretty concomitantly for a patient presenting in the situation. And in terms of antibiotics, we based our sepsis pathways locally. We crafted those as part of our IPSO participation. And for community-acquired sepsis at our institution, we recommend actually cefepime and vancomycin as our first antibiotic choice, which is, we acknowledge, reasonably heavy-handed, but would be likely the antibiotic therapy that we would choose for this patient.
Who's ready to optimize their nutrition this year? Factor is here to help you, Cribsiders listeners. Factor has chef-made gourmet meals that make eating well easy. They're dietitian approved and ready to heat and eat in 2 minutes, so you can fuel right and feel great no matter what life throws at you. Whether it's too much time in the hospital or too little time between after-school activities, Factor will help you. Their meals arrive fresh and fully prepared, perfect for the busy lifestyle we all lead. With 40 options across 8 dietary preferences on the menu each week, it's easy to pick meals tailored to your goals. Choose from preferences like Calorie Smart, Protein Plus, or Keto. At home, we use the vegan and veggie option and couldn't be happier. Eating vegetable forward has really helped us achieve our goals this last year. Factor can also help you feel your best all day long with wholesome smoothies, breakfasts, grab-and-go snacks, and more add-ons. So reach your goals this year with ingredients you can trust and convenience that can't be beat. Eat smart with Factor. Get started at factormeals.com/Cribsiders50 off and use code Cribsiders50 off to get 50% off your first box plus free shipping. That's code Cribsiders50 off at factormeals.com/Cribsiders50 off to get 50% off plus free shipping on your first box.
We keep on jumping into the bundles and medications. I really want to dial back into sort of some of the testing. I know you said that you're trying to individualize for some of our patients, but also when we were discussing some of the criteria for your Phoenix sepsis criteria, that there were some things that we have to get these in order to meet our criteria. I mean, so there were things like lactates on there, INR, parts to platelets, I think glucose and all. Like, would it be reasonable to at least add some of those basic labs as my first go? I'm gonna poke the kid. I'm gonna get my cultures, and am I gonna try to run those, or am I gonna say, I just want the cultures. I don't really need these. Kid looks sick enough. We don't need to do anything else.
Yeah, good question. And I think I suspect if we looked across the United States, we'd see some regional variation in the practice here for sure. A patient like this, I'm asking the fellow or the residents to get at least a BMP, a CBC, and I like to see a set of coags for anyone that I'm worried about sepsis. And I'll say that the coags are the things that I see overlooked the most commonly. And the reason I want to see them actually isn't so much so that I can see if they're meeting Phoenix criteria per se, but there's some real practical utility depending on the direction that this case goes. We've seen, for example, a lot of really aggressive group A strep in the last couple of years, and a lot of those children have presented with pretty profound empyemas once we've gotten the X-ray, and I like to know coags as well as the platelets before I think about putting a chest tube in those situations. The INR is also a really nice thing for risk stratification. If it's elevated, get an INR of 2 here. That can help you pretty quickly if you're still on the fence about sick or not sick. Once you've put some nasal cannula on, maybe the blood pressure is better after a bolus, to understand actually perhaps where that biomolecular response was in this specific scenario, if there's early indicators that the patient was maybe progressing to DIC as a result of the infection. Lactate's a great question because we know that it ended up in the score because a higher lactate is associated with worse outcomes, and so it can be a useful risk stratifier. The counterpoint, though, that I would imagine some of my ED colleagues offering is that a child like this shows up, they may not have been eating or drinking, they're mottled, they're hypotensive in part because of the infection, but also because of poor PO intake going into this. It can be tough to get a line in those patients initially. If you're putting a tourniquet on, placing an IV, I don't know how much to trust that initial lactate in that scenario. And are you just obligating yourself for a repeat in a little bit? The timing of that, can be determined by the trajectory of the case. So are things turning around pretty quickly, or does the patient look like they're going to need some additional support as you move forward? Is the ICU getting involved and thinking the patient's actually going to need to be transferred to the ICU? Those are in scenarios where I start to think a lactate's going to be more important. If I'm leaning towards a central line, then I have a more reliable source to repeat its measurements from. But I don't necessarily do a lactate right away. The other thing that can guide a lot of places is the availability of lactates in point of care. And we have those in our cardiac ICU. We don't have those in emergency department or the PICU here in Pittsburgh. And so I often lean away from them as an initial test, in part because of convenience, and it doesn't often change my initial management strategy.
So to summarize, it sounds like you're interested in at least a CBC, a BMP, PT-INR, PTT to take a look at that component. Lactate plus or minus, certainly during the progression, but doesn't necessarily go in the first stick. We talked about cultures, but we didn't actually be that specific. So I just wanted to very much clarify some of that piece. But yeah, Chris, go for it. Yeah, go in between.
Thanks so much. Because the other things I want to mention there would be absolutely. So cultures are important. I'll circle back to that in a second here. But the things that I didn't mention that I think are worth noting are that I think inflammatory markers are useful. And by that I mean C-reactive protein and procalcitonin. And no question there's some controversy about that, especially between the intensive care and the general pediatrics communities. I find them useful as a trajectory over time. Procalcitonin is also FDA approved as a sepsis screening tool, and so there is some regulatory backing to that test. It's not perfect. It doesn't definitively tell you is this bacterial, is this viral, but it can be useful. And actually, we have local data, and we've published this data, local and multi-center data, that shows that the combination of C-reactive protein and actually ferritin in patients with organ dysfunction is a really useful risk stratifier for mortality. If patients at our institution have an elevated ferritin and CRP in combination, the risk of mortality is actually quite high. It's more than 20% historically at our hospital. And so we actually have ferritin on our initial sepsis panel as well, and I encourage trainees to get it because it can be helpful in guiding some of the more precision therapies when it comes to immunomodulation if they end up with us in the emergency department, and it's a really cheap test. The other thing that you asked about were cultures, which is really important. And it's a timely question because we're in the middle of a blood culture bottle shortage across the country. So we're paying extra attention to how we're getting cultures these days. In the old way of, if you're putting the IV in the child in the emergency department, if you're even thinking about they might have an infection, often the nurses would draw a blood culture just because it meant sparing them an extra poke. And we're steering away from that, as I think many places are right now, until the bottle shortage is resolved. But getting a blood culture especially if you're starting to think about sepsis, can be a really helpful thing prior to giving that first dose of IV antibiotic in terms of guiding the de-escalation strategy. And the reason it's important, first and foremost, because it helps you hopefully target your therapies for the patient. It's also important because there's always been a little bit of tension between the infectious disease and antibiotic stewardship community and the intensive care community. And maybe a little bit is perhaps downplaying it some. But there is, there's ongoing discussions even at the professional society levels. The IDSA hasn't endorsed some of the Surviving Sepsis Campaign's guidelines in terms of diagnosis and treatment of patients with sepsis. And I think what we can do in terms of both best practice for patients, but then as good colleagues and antibiotic stewards ourselves, is make sure we're getting the cultures before we give the antibiotics so that we can craft a data-driven de-escalation strategy in the days to come.
One question I have is, so what about our patients with this respiratory component and we're getting this venous blood draw? Would it be reasonable to, if we're looking at the P to F ratio, is this a place where I could do a VBG and that would be acceptable? Or would you say I'm going to intubate them, or they're already on respiratory support? If I need a gas, I'm going to get an ART line, an ABG later. That's the only one I care about. Like, where do you fall on sort of that discussion?
Yeah, it's a really good question. I think the need for respiratory support for me is predominantly driven by the clinical exam, including the vital signs, what the patient's breathing pattern looks like, what their disease burden on an X-ray or other imaging test looks like, what their mental status might be doing. In this situation in particular, where we see hypotension and hypoxemia, is this a patient who's progressing to lethargy in front of us, and therefore, even if they're borderline in terms of needing additional respiratory support, may push us over the edge to do a little bit more rather than less. There's a lot of factors that weigh into how we support a child's respiratory status when they're facing a potentially severe or life-threatening infection. And a blood gas can certainly factor into that. When it comes to the Phoenix criteria, I think the VBG is not as useful. And the reason it's not as useful is you can't trust the PVO2 as a meaningful indicator of the blood oxygen content. And so you really are left with that SpO2 to FiO2 ratio, which you can calculate at the bedside. Or once an arterial line is placed, you can start calculating P to F ratios. But the initial resuscitation decisions are really guided by the exams and the assessments that we're trained to make as clinicians.
I do have a whole bunch more questions, but I feel like I'm taking over this thing. Does anyone have anything there, or else can I just keep going?
Go, Sam.
All right. So two more kind of here for kind of the workup component. We got kind of the blood culture discussion. When we're kind of going back to cultures, do you automatically do a respiratory or a urine culture or any other culture for these patients who you think are sick enough, or do you do that based on what their clinical exam looks like and how they might present?
Yeah, good question. So a few things come to mind with that. So it's difficult to get a respiratory culture if you're not intubated, especially in an 8-year-old. I think, as we all know, they're not going to great about producing sputum for you in a reliable fashion. Nasopharyngeal cultures haven't historically been relied on as a good surrogate of what might be in the deeper lung tissue. And then there's at least some, if not more than some, controversy about the utility of respiratory viral panels like the PCR-based tests in this type of scenario. One thing is worth mentioning here that I think is really compelling from the outpatient space is actually there's been some efforts looking at children with sinusitis in recent years and looking at their nasopharyngeal cultures and using those to guide some of the antibiotic therapies, and then even looking at how the PCRs might be useful in those patients as more immediately available test to guide who's going to respond to antibiotics and who isn't. That I think is hopefully foretelling some of the improved diagnostics that we might see in our careers as we proceed over the next several years. We don't have something like that, though, that's readily available at the bedside for lower respiratory tract tract infections, which it sounds like this patient probably has. So we don't have a great way of getting a lung sample unless we put in an endotracheal tube and either get a tracheal aspirate, which also has some controversy associated with it, or get a bronchoalveolar lavage by doing bronchoscopy. And so you often end up treating this type of situation empirically. The question about urine is an important one because at this age, at 8 years old, if you're turning up a bacterial pneumonia on a chest X-ray and you have a patient in respiratory distress who's hypoxemic, you'd say, it's the old, if it looks like and quacks like a duck, then it's probably the pneumonia in this case. There are other patients, though, or scenarios where you'd think, well, I don't want to miss a urinary tract infection in this patient either. Maybe they've had a history of UTIs, and two things could certainly go together. They have other risk factors, like they're immunocompromised. You get the CBC back, and it's showing some early evidence of leukemia, and this just happens to be the way that it's presenting with an infection. In that case, I'd absolutely be compelled to get a urine. Or you thought you were seeing respiratory distress, and you get the X-ray and it doesn't look right, and you look again and you think, oh, they're actually just really somnolent and hypoxemic because they're hypopnic, and this is something else entirely. And then the urine might prove to be really, really valuable. And so it's a great question, because I think pretty quickly as we start to think out loud about these things, it can reveal like the level of complexity that we face every day as pediatricians, but that we often, quite honestly, take for granted. And one of the other aspects of this case that's brought to mind is that in general, children who show up like this to a children's hospital tend to fare really, really well. That it sounds like this child has a life-threatening infection. I have the utmost confidence if they showed up to any of our institutions or really any children's hospital in the United States, they're going to receive top quality care, get what they need, and the chances of walking out of the hospital are really, really high. And I don't, especially the trainees, I often like to reinforce to them that I don't know that they always realize just how many lives they're saving. That you reverse the clock to an era without penicillin or without some of even the more broad spectrum antibiotics that we have, and this situation isn't going to end well. And so we just take for granted how routine life-saving therapy is these days.
Awesome. No, this is fantastic. And we're talking about each as an individual case. And when we come to an individual case standpoint, it's like, okay, if we think respiratory stuff, get a chest X-ray. If we're thinking it's, systemic and we can't tell where it's going and urine might be on a list, we'll get a urine. But it's not like it's an automatic test, it sounds like, from anything. Short of the blood culture, sounds like the only kind of automatic culture we'd be doing prior to giving some sort of antibiotic, which we're about to talk about when we get to medicines. Before I hit this question, Chris actually has a complete follow-up that he wants to hit. So we're going to actually hit that, and then this is going to be a teaser for when I come back.
All right. So going back to some of the questions we have about cultures and PCR and everything we were talking about before, this may be coming from a place of someone who's a little more ignorant of inpatient pediatrics, as I do a lot more adult hospital work. There's a lot more recent literature in the adult medicine world about doing MRSA nasal swabs and using that as testing, because it's got great negative predictive value for all sorts of infections, whether it's pneumonia, bacteremia, osteomyelitis, those types of areas, and using that for de-escalation of MRSA antibiotic coverage. Is there any thoughts about using that in these populations? It's obviously pretty easy to do and can be done. Do we see this in the pediatric world?
Yeah, that's a great question. And I've looked at the adult literature on this front because there's a paucity of pediatric literature related to MRSA nasal swabs and the utility for a de-escalation strategy. So it's really difficult to say conclusively how we should be using these things. I would say my individual practice is I often will obtain a nasal MRSA swab, and actually more than nasal, so the nasal, the skin, and the rectal swab for a patient I'm treating for sepsis, because it gives me something to go by as part of a de-escalation strategy a couple days down the road. And because there is some literature, and I can't claim to know the adult literature in all its detail, but there is some literature that I think you're mentioning that suggests that it can be helpful as part of a de-escalation or as part of a continuation strategy. If this is a child who ends up revealing some bilateral patchy infiltrates on their X-ray, or I'm already starting to think, gosh, could this be staph? And then I'm wondering, do I need MSSA coverage or do I need MRSA coverage? And I don't think the child needs to be intubated intubated, so it's going to be a difficult question to answer, but their nasal swab comes back positive, then I'm going to be really inclined to treat them as if they had a MRSA pneumonia, especially since the consequences of that can be so devastating. And so I lean towards collecting data in these types of scenarios. I also think it's an emblematic example of where we need just more evidence in general. And the additional thing I would say is just going back to that tension between folks who really are strong proponents of antibiotic stewardship versus the sepsis guidelines, which recommend starting broad spectrum empiric antibiotics early and even combination therapy, is that it really is, we're in a situation of an irreconcilable tension currently because of the lack of great diagnostics in this space. And we have to wait at least 48 hours for a culture to reveal itself before we can even start to say, okay, now we have some more conclusive evidence that we can back off on things or that we need to continue stuff. We live in an area where both camps are right, and we just need better tools.
Mm-hmm. So I'm going to complete this kind of diagnostic workup piece before we move on to the next side with just a POCUS question. So this is kind of a new piece that we can do in the emergency room. We can do anywhere. We can do in the floor. We can do in the ICU. Is there any value to POCUS on your diagnostic sepsis kind of workup before we get to treatment?
Yeah, this is something that we have really been working to emphasize and have integrated into our curriculum over the last several years at our PICU program. And I know our emergency department has some really strong POCUS champions as well here in Pittsburgh. And I think that there's growing recognition of the utility of POCUS for a variety of purposes in pediatric patients. It definitely plays a role here. And I think the things that it plays a role in are hypotension, and ultrasound is a really easy tool once you've been trained on it to do a quick screen of the qualitative assessment of the heart function. Is this a patient who's presenting with myocarditis? Is there more of a zebra scenario here? Do they have a pericardial effusion that's actually emerged? Again, something that we've seen with the group A strep infections over the last couple of years. That x-ray that's showing a blunting of the costophrenic angle, what does that actually look like under POCUS? Can we take a look at and see if there's pleural fluid there? If there's pleural fluid, is it simple or complex? There are techniques that you can apply POCUS in to look at potential fluid responsiveness. As it's outlined here, the case doesn't exactly lend itself to that because the best quality data we have for those scenarios are in patients who are already intubated and receiving neuromuscular blockade. But there may still be some utility in looking at like IVC caliber in these patients and developing an individual sort of gestalt about that over time with using POCUS. And so it's one of those things where I think we need a more systematic approach. There's growing adoption of it. It can be incredibly helpful. And I think it's going to be exciting to see how it continues to integrate into our practice for these types of scenarios.
All right, that's a lot about diagnostic testing. Sorry, everybody. For the also ICU doctors that are in the room, Alice and Zach, do you guys have any other questions you want to ask from a diagnostic standpoint, or we can get into kind of first line medicines for patients with sepsis? Obviously we've teased this throughout the entire episode, but
No, I don't think so. I think it's job well done.
All right. And that brings us to the end of part 1. Please return next week for part 2 as we discuss treatment for sepsis. We talk antibiotics, we talk fluids, we talk pressors, and everything you want to know. So stay tuned.